afternoon, everyone, and welcome to our FAST WebEx training. Please, a reminder, if you are not speaking, to please put your phones on mute or your headsets on mute. I want to welcome Nicholas Thorpe from CAPRAC, and he'll explain a little bit more about what that is. He is a original FAST team member. He took his training under Wendy Pulley when she started the FAST program here, and he's been a very interested member and a very good supporter of our program. So he is here to talk about the state medical support shelters and what they're all about and how FAST can best integrate with them. Thank you, Nicholas.
So good, I guess it's good afternoon. Again, sorry for my technical difficulties on my side, even after we sort of practiced this. I'm actually currently down at Campbell University attending a public health and preparedness Ebola tabletop exercise. So I'm doing this a little bit remotely. But yeah, I'm the emergency planning and exercise specialist with the CAPRAC Healthcare Preparedness Coalition, and hopefully through this presentation we can work to identify or increase our knowledge on how the state and how coalitions support the state in providing special medical support shelters during crisis, and hopefully identify roles that FAST team members can support in these operations, and sort of what the expectations are or should be for FAST team members if they are deployed to a SMSS to provide assistance. So feel free to engage in questions. I'll answer them as I'm able to, but hopefully this will be a good discussion. And I do apologize for any background noise. Again, I'm on a college campus right now. So let's jump in, and hopefully this slide will change for me. Well, it was all right. Here we go. So today we're going to be talking about again the state medical response system. That's sort of the bigger picture of how the state manages the medical pre-hospital care and disaster preparedness for the healthcare infrastructure. We'll talk about the role that healthcare preparedness coalitions have in the state and how you can get engaged with your coalitions. We'll specifically talk about the state medical assistance teams and the medical reserve corps. Those are the volunteer and operational arms of the coalition. And then we'll wrap this up with what a state medical support shelter is, what it does, and how FAST team members can support those missions as they occur. So the state medical response system. State medical response system is part of the North Carolina trauma system that is supervised, and the oversighting agency is the North Carolina Office of Emergency Medical Services, or OEMS. Through this process and within the trauma system, they are responsible for all pre-hospital care, transport operations, trauma-related programs, and disaster preparedness and response activities. And so this is pretty much how, if you had a traumatic injury, how it's governed, what hospital you are going to end up at. And so this is something that OEMS has been working on for years now. So within this trauma system and this trauma system concept, and under that branch of public health or healthcare preparedness, you get the state medical response system. And it's how all these different entities, EMS, public health, healthcare coalitions, emergency management, it's how we all come together to solve the problems related to the healthcare infrastructure in the state. And of course, they just started mowing the grass next to me. All right. So all these systems are they live within the trauma region.
Hello, this is Sherry. Can you please put your phones or headsets on mute, please?
Didn't realize I had that such an impactful voice. Oh, still there. Great.
Okay. Everyone on mute? I think that resolved it. Nicholas? Nicholas? Hello? Nicholas? Nicholas?
Can you hear me all right? Hello, hello, hello?
Hello. There we go. I can hear you
All
now.
right. So the state medical response system is similar to what you would see within like the Citizen Corps program that manages CERT. And it's that same concept. So within this SMRS system, you get 8 regional state medical assistance teams, and they mirror, they're very similar to the DMAT teams, the disaster medical assistance teams at the federal level. So this SMRS program sort of matches them at the federal level, and they have these 4 primary missions, and that's to support medical support shelters, which we're talking about today, field medical care, so that's response to special events or public health emergencies within the community, provide logistical support to support the healthcare infrastructure, so that could be anything from direct resources, subject matter expertise, supplies and equipment to support the medical needs of a community, and an alternate care site. So that is tied to our mobile disaster hospital capabilities. And I might have to move as this lawnmower gets close to me. So I'm trying to, hopefully you guys can still hear me all right. So within the trauma system and the regions, they break it up based on the level 1 and level 2 trauma centers. So here in North Carolina, we have 8 level 1, level 2 trauma centers. So that means we have 8 state medical assistance teams. They each are responsible for a set region of counties to coordinate these responsibilities: trauma care, transportation, related education, and then this is where I live, is facilitate the healthcare preparedness coalitions. So instead of coming up with a new map and a new way for the state to be broken into in terms of preparedness, OEMS decided to just contract with these level 1, level 2 trauma centers and use the existing regions as a base. And this is what the state looks like, broken out across the 8 regions. So wherever you are in the state, you should be able to identify and locate the Healthcare Preparedness Coalition that's nearest to you. The region I'm closely associated, or the region I work with, is here in the middle with the CAPRAC under Wake Med Health and Human Services. So I like to say I work for Wake Med, but I don't really have any Wake Med responsibilities. I support the 5-county region healthcare infrastructure. We work very closely with our 2 partners in Durham and in Orange County at the coalition level with their 2 coalitions as well. And because Duke Raleigh and UNC Rex are both located in Wake County, is why Wake County sort of split into a couple different colors. But Wake EMS is required to associate with us at the CAPRAC level. And I guess I didn't mention that. All hospitals in the state and all EMS agencies are required by law to associate with a trauma region and actively coordinate with the coalitions and those regions to improve the overall pre-hospital care and disaster preparedness for the healthcare infrastructure here in the state. So let's talk about a little bit what I do for a living here in the healthcare coalition world. So again, our mission here is to provide access to medical care to all residents before, during, and after natural and man-made disasters. And it's our job to help try to facilitate the pharmaceutical, physical facility, triage, tracking, and transport coordination for patients as identified by our partners. So again, we are the side of the world that deals primarily in the healthcare side. These are just a few of our partners that we actively participate with and collaborate with on increasing the overall healthcare preparedness in our region. As you can see, there's EMS is in there, emergency management, healthcare facilities, hospitals, and even a few volunteer groups. So we are open to anybody who could potentially touch the healthcare preparedness infrastructure or healthcare infrastructure and supporting those needs during a crisis. So we're open to a lot of those organizations. All right. So let's talk about sort of how we do what we do and how we utilize volunteers for that purpose. So the State Medical Assistance Team is a designated state resource. Each of the RACs or each of the Healthcare Preparedness Coalitions house a Type 2 team. And when we talk about typing, it's a FEMA term of how large and how capable that team is. So Type 1 being the most capable and largest type team out there. So usually you would see a DMAT team at the federal level, be a Type 1 DMAT team. So our Type 2 SMAT teams are the second largest and most capable entity of this resource out there. Like I said, there's 8 of them across the state. It's comprised primarily of medical professionals or medical licensed professionals. And they they go through a extensive 2-day training where they learn how to work within the medical support shelter, work within a mobile field hospital, and as well as hospital decontamination. And their primary mission is to provide that acute care during a medical surge event or in a shelter capacity. Like I said, these guys these individuals are considered state resources. So when they come out, they get a state badge, like very similar to what the FAST team and some other volunteer organizations have. And when they are activated, they are expected to find the time to be able to deploy for at least 7 days. Normally we say 7 to 14 days. The typical mission is 7. And the benefit of being part of the team, or one of the benefits for our licensed medical professionals, is that if they are deployed on a state mission, their host agency, so their hospital or EMS agency that they work with, if their home agency continues to pay them while they're deployed, then their agencies are eligible for financial reimbursement for their employees' time volunteering with our organization. So that's one of the big benefits of our SMAT members. Again, they go through a 2 full-day training. Our trainings are located in Garner. That's where we do our training. We require all our, yes.
This is Sherry. What does the 800 stand for?
The 800, right. So each of the teams have a number designation. So ours is 800, and it reaches back to the fact that WakeMed Health and Hospital was the last level 1 or level 2 trauma center to be designated in the state. So there's eight others in the state. So we're SMAT 800, and like our partners over at Duke are, I think they're SMAT 500. And so there's 1, 2, 3, 4, 5, 7, and 8. Or 6, 7, and 8 across the state, and based on when their hospitals were designated as a trauma center.
I see. Thank you.
Yeah. And sorry if I'm talking too fast. Feel free to tell me to slow down, or if there's a question from previous slides, feel free to bring that to my attention. We require all our volunteers to be part of, be within the terms system. For verification of medical licensures and notification purposes. The SMAT training is a statewide training, so you can take the SMAT initial 2-day training anywhere in the state and then become associated with any of the teams. So you live in the Triad region and you want to associate, you can go through their 2-day training and then associate with our team. And we do have some members from the Winston-Salem area that will come down and volunteer with us, even though they have gone through training in a different part of the state and live closer to another region. So that's sort of the volunteers' decision to make. But we are in terms, and that's how that's our primary method for deployment and volunteer verification. Again, the commitment level for SMAT members and any of our volunteer organizations is all based on our members' interest and availability. But for our SMAT members, we try and place a higher expectation that if there's a state-sanctioned mission that's coming down, sort of like Hurricane Florence, Hurricane Dorian, and stuff like that, that our SMAT volunteers especially try to find the 7 to 14 days to come out and work. And then as an ongoing effort to maintain skills and expectations for deployments, we highly encourage our volunteers to go through ongoing training every month or every other month. And those topics will range on various items, from how to put up a medical tent to how to work within an austere environment, how to provide that care to individuals when you are outside of a hospital system and not used to working with all the benefits and equipment that come with working in a hospital environment. Of course, the benefits that we offer to our volunteers through this program is the training opportunities. You get a lot of additional training opportunities in areas that you wouldn't typically get in the medical profession, and then same with our non-medical volunteers as well. We try and train them up so that they can fulfill basic medical roles, so CPR, first aid, and stuff like that, but also how to do triage and sort patients during mass casualties. Our SMAT members work special events, so our SMAT team deploys to support other coalitions such as Wings Over Wayne and the Cherry Point air shows. They'll go out there for 2 or 3 days, live on cots and in the tents, and provide medical care to spectators of those events, same with the Outer Banks Marathon. So you get that opportunity to work across the state. Of course, one of the big benefits is you'll be able to grow your medical and non-medical professional networks. So people who are looking for a job or want to move into this career of disaster medical response, we provide those opportunities to put you next to the people who are doing the job day to day and learn from them so you can advance your own self. And then we talked about the backfill reimbursement for our team members. Any questions about the SMAT team? I don't have any chat boxes up, or is there anything, Sherry, that you know of that I should hit upon anything we've talked about so far?
I don't have any questions. Does anyone else at this point? Okay.
So the Medical Reserve Corps is sort of the second arm of our operations here in the coalition. Again, most of the coalitions have a component of a Medical Reserve Corps. They all sort of operate differently. But here's the sort of the bigger picture. We were created after the attacks on September 11th, 2001. A bunch of medical professionals flocked to New York, Pennsylvania, and D.C. to try and provide medical care to individuals impacted by the attack. And what they found out is when they arrived in those areas, there was no way for their credentials to be verified so that they were in good standing and were able to provide the care that they wanted to offer. And this became a secondary disaster in New York specifically. So following those attacks, President George W. Bush created what we know now as the Citizen Corps program, where you got the Community Emergency Response Team, or the CERT teams, and you got Medical Reserve Corps, Senior Corps, and a bunch of these other volunteer groups were sort of housed there. President Bush asked in 2002 that all Americans donate 2 years of their lives towards volunteering, and that specifically there needed to be some sort of component to organize the medical volunteers to be utilized during these types of events. And so that's where you get the Medical Reserve Corps. Currently, there's around 997 units of us throughout the United States. So again, anywhere in this state, you should be able to get plugged into an MRC through a healthcare coalition or a public health entity. But if you decide to leave North Carolina, you should be able to locate a MRC unit close to you. So again, very similar to CERT, only we focus on the medical infrastructure and components of a disaster. Very similar to our SMAT teams, this is sort of the entry level into volunteerism in a disaster healthcare world. We here in our coalition, we offer a 3-hour orientation. Again, it's located in Gardner. We require them to be in terms with 100% profile completion, and that allows us to meet federal requirements, again, for verifying any kind of medical credentials. let's see here. Again, everything the Medical Reserve Corps does is pure volunteerism. So even if you deploy on a state mission, you're doing it out of the kindness of the heart and the warm, fuzzy feelings you get inside your stomach for doing good work. Again, everything we do is based on interest and availability. So that's what I spend part of my job doing, is trying to find interesting things all the time so that people can feel encouraged to come out and volunteer. And then we hold seasonal meetings to keep tabs and make decisions on the pathway forward for our MRCs. Again, we provide ongoing training opportunities on various topics, whether it be skill labs to help increase the basic medical skills of our non-medical volunteers. Again, CPR, first aid, stuff like that. We are offering a skills lab coming up in December that's going to talk about how to respond in the first 5 minutes of a medical emergency. And we'll be offering the Stop the Bleed curriculum during that training as well. So again, providing our non-medical and medical volunteers opportunities to learn how to use tourniquets and stop massive bleeding during incidents. Again, we're going to put you right in contact and in close proximity to people in the medical profession, so that if you wish to grow your network or move into this career field, you'll be next to people who are doing it every day. And then in the MRC program here, in our program here in CAPRAC, we have various incentive programs in place to try and encourage people to actively volunteer with us. So the more you volunteer and engage with our programs, the more chances you have to win prizes or earn MRC gear that can be used on future deployments. And that's how we sort of keep our volunteers engaged throughout the year. So in the big picture, this is sort of how it looks. Federal dollars come from Department of Health and Human Services to OEMS. OEMS being the state oversight agency, coordinates with all the level 1, level 2 trauma centers who manage the RAC systems where healthcare preparedness falls, or healthcare coalitions fall. The healthcare coalitions then manage the various volunteer programs such as MRCs and the FMAT teams. And then specifically here in our region, the capital region, we have formed what we call the North Carolina Triangle Coalition, because when you put our coalition, Duke's coalition, and UNC's coalition all together, we take up about 30 some odd counties, I think, worth of healthcare infrastructure. So the more we three can be all on the same page, there's more consistency across the 3 regions for healthcare preparedness. And that's us working together there. So we can move into sort of what a medical support shelter is and does, and the role FAST members can fill within a SMSS. So state medical support shelters, they're always going to be located in a fixed facility. So this could be a church, hospital, or school. The facility is always going to have bathrooms and shower facilities. We learned after Hurricane Florence that these facilities need to meet ADA regulation requirements. And so if there's a question to that, we have resources in the state that we reach out to and bring. So in Dorian, we got an ADA compliant bathroom trailer to be utilized to help increase our capabilities and capacities in the state medical support shelter. So the facilities have to meet all the same requirements as most general population shelters do, and then some. So and then some is on-site generator or connections to generator. Again, during Hurricane Dorian, we set up the state medical support shelter at C3 Church in Clayton. They had a generator, but it didn't run all their facilities within our location. So the state actually contracted with the church to build a new transfer switch and increase their capabilities so that we could bring in a generator to just plug right in, and it would give us backup power to the entire facility should we lose power. All the coalitions carry resources to be able to immediately set up one of these shelters for up to 60 patients. During Hurricane Dorian, CAPRAC and Triad coalitions partnered together to set up a 60 to 80 bed shelter, medical shelter, with the surge capacity to 120. So again, all our stuff is interchangeable. So if one coalition can't do it on their own, we definitely partner with other coalitions in the state to increase our capacities. Within these shelters, we carry a full pharmacy capability. to meet the medical pharmaceutical needs of the patients that are in there. This includes tube feeding materials and other basic medications. Normally, we'll staff it with 2 pharmacists as well. North Carolina Department of Public Safety, through their prison system,
no one has contacted me yet. They will actually
parole
contact
officers
you first. You
will serve as the
now that you're dealing
security
directly with the leasing officer.
Security force for our shelters, and then the shelter itself is managed collaboratively between North Carolina OEMS and coalition staff. So they work within that unified command structure. It's OEMS's responsibility, but it's all our stuff. So coalition will staff a lot of the medical and general staff positions, while OEMS fills a lot of the command staff positions. So again, incident command staff is going to be broken down between OEMS staff and healthcare coalition staff. For instance, during Hurricane Dorian, CAPRAC served as the operations section chief, medical branch director, while Triad served as the finance and administration section chief, while OEMS filled the incident commander, liaison, public information roles. When we set one of these shelters up, we're bringing in trained staff of 30 or plus that include physicians, physician assistants, nurse practitioners, paramedics, nurses, EMTs, and then certified nursing assistants. So anything, so we can provide that kind of level of care or assessment to individuals who would normally be housed in a long-term care facility, nursing home, assisted living, or reliant on home health care. So these people are already coming to us with medical conditions. Our non-medical volunteers, we staff as needed, and they'll fill mainly roles in supporting the overall logistics of the shelter. So this could be medical logistics, i.e. resupplying various nursing stations with supplies, tracking resources, to helping clean up the facility to ensure a safe environment, to helping hand out food, feeding patients, or just providing that camaraderie with the patients and family members for ease of mind.
Nicholas,
So,
this is Terry again. Yeah. So during Dorian, there was also the state coordinated general population shelter, and there was some folks, medical folks that were deployed there. Was it like a quarter of what a medical shelter would have seen the staffing, or how was that in relative to a medical shelter?
Right. So the state coordinated shelter that was set up during Dorian at the Sears, old Sears department store at Northgate Mall in Durham, that was, in my understanding, the state's attempt to develop or to establish a large-scale general population shelter. So with what we learned from best practices and lessons learned from Hurricane Harvey and some of those other storms that impacted Florida and Houston a couple of years ago, was that if you're going to house a bunch of people in a general population shelter like they did, there needs to be a stronger medical component in those shelters. So the volunteers and medical professionals that we sent and that were brought in from Tennessee to staff the state coordinated shelter, they're there to provide more of that acute pre-hospital care. So it's slips, trips, and falls, try to meet basic medication needs and coordination. It's those medical individuals at the state coordinated shelter, there to try and prevent the medical surge of the local healthcare infrastructure. So if it's someone just needs a Band-Aid, they should be able to get that in the shelter. And then it's whatever the expectations of, in this case, the state would be for what level of care should be provided at that shelter based on the medical professionals there. So if they had a doc, a nurse, and the capabilities to do stitches or sutures, local EMS or state EMS could say, anything that doesn't require an ER visit should be able, that isn't acute or immediate, should be able to be taken care in the shelter. And then it's the coalition and the state's responsibility to provide the staffing and the equipment to be able to perform that level of care in that facility. Does that make sense?
Yes, thank you so much.
Yeah, so the care that we're primarily providing in a state medical support shelter is more in line with the same level of care that you would find in a nursing home or a long-term care facility. These are individuals who need constant care, 24-hour care, either through ventilators, tube feeding, and other. I think I have a slide on exactly what we put into a medical support shelter, which I think is right here. So individuals who are coming to our shelter require active monitoring, management, or intervention. When they come to us, they have to be triaged, just like if they were going to an ED before they're placed into our shelter. And the way they get to our shelter is through a approval process through local it could go through a local emergency management to state emergency management over to OEMS for a consultation on that person's specific medical needs. And then if they are approved to go to the shelter, then the state and local jurisdiction coordinate that transportation of that individual from their home or from that nursing home to the shelter. And then when the disaster has passed, it is in the responsibility of the state and the local jurisdiction to get that person back home or back to a new facility. And so the state medical support shelter is not someplace where if you had somebody in a general population shelter and the shelter manager doesn't think that person belongs there, they can't just say, go down the street to the medical support shelter. They'll take care of you. There's a approval process for that. And these are the examples of individuals who could be approved to be placed into a state medical support shelter. Again, 24/7 skilled nursing requirements, hospice patients, ventilator, trachs, wound management. We see that a lot with our bariatric patients, bedridden, of course, and then individuals who have been evaluated by a medical professional. So if there was somebody in a general population shelter that FAST team member said this person, is not going to be able to sustain a healthy, manageable life in this shelter, you could bring that attention to the shelter management or emergency management or OEMS, human services, and get them evaluated either through telemedicine or other various resources that the state can leverage to get that person evaluated on whether or not they need to be transferred to a medical support shelter and or to assist you in identifying what would make that person ability to stay in that general population shelter more successful and provide them the access that they need. So I'll show you a few pictures of SMSSs or state medical support shelters in the past. This is Hurricane Florence, Cherry Hospital in Goldsboro. This was a decommissioned psychiatric hospital. It was a good idea at the time for what we had. Again, a hardened facility. We did lose power there for a little bit. Army Corps of Engineers was able to come in and provide a generator to ensure overall power. I don't think we'll ever go back here because of the multi-story building for the shelter. We also put over 100 people in here, about 60 to 80 patients with another 60 to 80 of their family members or primary care givers. But that is that shelter. This is sort of what it looks like in the inside. Each of the patients are provided a Westcott. This is a medical bed, if you will. The back ends do elevate to allow for that kind of comfort. We can also attach IV poles and guardrails to prevent falling off this. But everyone who comes into the shelter is provided a care kit, a pillow, and blankets like you would find at normal shelters as well. And that's sort of what the patient living area looked like. We have privacy screens for people who require privacy, or we think it just would be better for them to be sectioned off, especially for when using the bathroom and stuff like that. We have bedside commodes and other equipment and resources at our disposal to ensure that we are meeting those needs of those patients. That big gray case in the middle of the hallway is what we call a Stevenson case. This is essentially a mobile nursing station. So everything in that case there is what you would typically find at a nursing station. So they can provide that level of care that the patient might need while they're in the area. Medical supplies, when we deploy, we have 3 or 4 trailers that we deploy that carry all of our biomedical equipment. So ventilators, oxygen tank, tubing, telemetry. You can sort of see it all lined up there on the wall there in Goldsboro. And we're providing, again, that level of medical care that is needed for each patient as they come in and as they're assessed. And that's sort of what the parking lot looked like at Goldsboro with all our trailers lined up. That's our mobile disaster field hospital trailer. We primarily use that because it had all our bunks and beds in there, so we offloaded that for staff billeting. And again, that's just another picture of one of our shelter trailers arriving or being offloaded at Goldsboro. Living within the shelter, you know, you're going to be provided food every day. Patients get 3 meals, staff get 3 meals. Again, you're in a hardened facility with air and access to food, water. Could be MREs, it could be catered in. So we tried to turn that facility into a makeshift long-term care facility, if you will. Again, it takes 30 plus people to staff that, and that's medical and non-medical, broken into shifts. And in this case, because this was a decommissioned hospital, they were able to just set up shop in the already established nursing areas. Our volunteers are staff for this shelter. They live on the same cots that the patients do. I think this one, the one in the middle there is from a DMAT team who brought his own, but again, we're putting everybody on West cots. We're moving away from that to air mattresses now. But again, those are sort of the living conditions. And then again, that was the full team when they were getting ready to demobilize the hospital in Florence. So moving forward in time to Hurricane Dorian at C3 Church. C3 Church is going to be and is a designated location for an SMSS. So anytime that the state requires a state medical support shelter to be opened, depending on impacts that are occurring from that incident, C3 Church will be utilized for that mission. So we'll be going back there the next time a hurricane or major incident occurs that doesn't impact Johnston County or the Caprac region. This is sort of what it looks like inside, again, with the privacy screens as we were able to set up. Each of the patients had a bed, care kit to be comfort to sleep on. And if at all possible, we try and house both the patient and their primary caregiver or family member next to each other. So unless we get filled up, the family member would sleep across from them or next to them in a Westcott. And then the bottom picture there, sort of before and after. This is their fellowship hall there at C3 Church. Bathroom and shower trailers. Again, like I said, C3 Church did meet ADA compliance, but they didn't have enough of access for the amount of patients or individuals we were expecting. We were anticipating to have to surge to over 100-bed shelter, so we asked FEMA to bring in their ADA compliant bathroom trailer, and then we had a shower trailer brought in. The shower services within the facility, I think, met all the requirements that needed for a SMSS. You also realize that during these type of operations, a lot of our patients aren't getting up to go to the shower. We are providing them sponge baths and other type of cleaning on a regular basis from bedside. Again, staff sleeping areas on Westcott's, and these are in various rooms within the shelter. This was a little bit more luxurious than Hurricane Florence. The staff had a little bit more space to spread out and within their designated spots. Again, staffing, medical, non-medical professionals. These pictures are from some of our EMTs, nurses, docs, physician assistants. Again, it's coming fully staffed with fully trained medical and non-medical professionals that know the necessary needs to meet shelter requirements. So let's talk about how fast. Any questions, Sherry, or anything I need to touch on that I haven't?
Done a great job with the overview. Thanks.
All right. So let's talk about sort of some staff considerations for FAST members as if you guys get deployed to a state medical sports shelter. I guess the key points is to understand that the shelter is managed under the authority of OEMS and is under at the direction of NCEM. So this isn't a Red Cross shelter. This isn't a DSS shelter. This isn't a pop-up shelter at a church that a community thought it'd be good to open up. So when we have to open one of these shelters, it's at the direction of emergency management and OEMS. So with that comes all the rules, responsibilities, and regulations that apply to being able to provide that kind of care in that type of facility. The shelter is a medical shelter for individuals requiring medical care. So if we understand the medical community and understanding the level of care and regulations that hospitals and long-term care facilities have to meet, we are striving to meet those same requirements within the shelter. So the good example that we like to use is we might not have enough ADA bathrooms for 60 patients, but those patients aren't getting up to go use an ADA compliant bathroom. They are using a bedside commode or a bedpan. And so things for FAST members to consider if they come to a shelter is to really assess what are the needs of the patients and are their needs being met versus if we have enough access to a certain facility. And I think I talk about this moving in another slide maybe, but one of the things that we would like to stress to FAST members and something I would like to have you guys consider is when you come to a SMSS shelter is to look at it also through the lens of the family members and the staff. Is there enough facilities and access for family members who might be elderly themselves? They might not require constant medical care, but are their needs being met, and do they have access to the needed supplies or resources for them to either continue to provide assistance in caring for their loved ones at the shelter, or maintain their own healthy lifestyle within that shelter? And that goes with staffing as well, staff of the shelter.
Nicholas, this is Sherry. Would a patient actually bring their whole family with them, or is it like a 1-to-1 caregiver or family member ratio?
So traditionally, and what we're trying to work away from is trying to identify the primary caregiver and provide them space in the shelter. During Hurricane Florence, it was entire families at a time. What we've been working with OEMS and locals is if a SMSS or medical sports shelter is opened up in a county or in an area, that the county then also follows suit and open up a general population shelter. So if one person is a patient and they have 10 family members, we're going to try and identify a primary care provider or a primary caregiver within that family or immediate family member to stay with them, and then have everyone else stay at the shelter. If they have the capability, they have full access to come back to the medical support shelter and visit, but that would lessen the footprint and impact that those non-medical individuals would have on the shelter.
Thank you.
But like I said, some of these members that come to us, their member might be bedridden and their spouse is just as old, just not bedridden. So their needs need to be also accounted for. I think we do a fairly good job at trying to meet those needs, but I think that is something that a role that FAST members can help out with, to take time to talk to the family members of the patient to ensure that their needs are being met and they have the access that they need. All our shelter staff are well trained, and in most cases are licensed professionals. So the care that they're providing is the level that they've been trained to, and it's meeting those requirements. Let's see, patients in the shelter have been specially approved. Like I said before, the people in the shelter have been specifically evaluated by a medical doctor or physician to be placed in that shelter. And if that individual shows signs and symptoms of something that the shelter cannot handle, the shelter is staffed with an ambulance strike team that can then transport that patient to a hospital for advanced medical care. So everyone in there is not just coming off the street, they've been approved to be there. And then the equipment that we bring and leverage in staff and setting one of these up is meant to meet the needs of individuals who who require 24 access care of some sort. So again, ventilators, oxygen, bedside commodes, bedpans, walkers, wheelchairs. We bring all that equipment with us. It's one thing as a FAST member, to go into a medical support shelter and say, you know, this bathroom isn't big enough, versus if this person we think can be more mobile, you know, if you had a walker or a wheelchair, it might just be something that we haven't had the time or ability to assess, and or it's equipment we haven't pulled out of our trailer yet, that you could be helping us identify how someone can be more self-sufficient in the shelter, and we just haven't had that ability or conversation with that individual yet. And so little things like that. Yeah.
This is Sherry again. As you're going through and talking about this, I'm wondering if there's the availability of, just like on a short-term basis, say we have a person in a shelter, a general population shelter, that might need some oxygen. Is there, you know, a chance that we can utilize the oxygen at a medical support shelter? Some of that equipment, not necessarily bring the patient there, but take some of the equipment to the general pop shelter.
That is going to be hard. One of the roles that the coalition can do, and what we did during Florence, is try and help either that shelter location or that county responsible for that shelter identify a vendor, or be in touch with the hospital to leverage resources to be delivered to the general population shelter directly. Okay. I don't think, I mean, I'll go out on a limb. I don't see right now a pathway for where we would ever take resources out of a medical shelter and deploy them long-term or short-term to support a general population shelter. But if a FAST team member sees someone requiring oxygen in a general population shelter, it might be worth, in knowing that a medical support shelter is open, it might be a good conversation to at least start having of, should this person be better served in a medical support shelter, and starting that conversation. If they do, then you just increase that person's capacity to survive during this, you know, traumatic event. And if they don't, you know, then we can find other resources or brainstorm other ideas to get them the services that they need. But that is a role that the coalition can try and help fill outside of our support of a medical support shelter. Yeah, okay. So potential areas in which FAST can assist in improving the operation. So I think I talked about some of these already, but identify areas in which caregivers or family members' needs could be improved while staying in the shelter. It should be a foregone conclusion that the patient is being well taken care of, and we're going to do everything we can to support the patient. I think we do a good job at supporting their family member, but if there's an area in which we could improve on, or an area in which FAST could specifically focus on, is really evaluating if that caregiver or that family member's also needs are being met. Assist with social services needs of the patient. So this could be patient registration or patient discharge. Again, I think this would fall back on a FAST team member's already, you know, either day-to-day job or training capabilities. But again, in understanding how we get people into the shelter and then how do we discharge them from the shelter, a lot of that is reliant on a lot of social service work. And if FAST team members have that kind of expertise or understanding, it could help make that process go quicker, and allowing that person to get back to a normal life. And that's one of the critical components that we've identified in the shelter, is planning for that discharge as soon as that person arrives into the shelter.
And there was a national report that was put out regarding patients in shelters that went in medical support shelters, or even put into hospitals during the storms, or and then ending up being released to a more restrictive setting, which is something that, of course, the disability advocacy community wants to avoid at all costs. We want that people to go back to facilities or their homes in a least restrictive setting. So if we can use FAST to assist in making sure and ensuring that, we would love to be able to do that.
Right. I think another component that I think FAST would be good at or could have a benefit at is, verification of equipment at home or verification that where they are going to be placed is going to meet the needs of that individual. And I know during Florence or during even Hurricane Matthew, when we tried to discharge patients back to their homes were, might not, I mean, we didn't put anyone in an environment where they shouldn't have been, but if we had the capability of say, hey, if someone can go to this location, with a family member and verify that the location is suitable for that patient's return, it then would help cut down, like you said, the inappropriateness of placing that person in a long-term care facility or at a hospital where they're not going to have the same kind of access. They'll get all the care they need, but their mobility and independence is going to be compromised from that maintenance, if you will. Within our shelter system, another gap that we identify is mental health. So a lot of times we focus on the physical health of not only the patient, or we focus primarily on the physical health of patient and family members. What we are trying to do better at is also ensuring that we're meeting the mental health needs of our patients and our family members, and that of the staff. So again, a FAST member coming into this type of an environment with this sort of more open mind as to what is needed beyond the physical needs of the patient, staff, or family member is to have a good understanding is that if the mental health is needs and care is being met for the patient, the staff, and the family. And so, again, another area that I think FAST could be a benefit is either bringing that to the attention of shelter management or being able to provide that kind of service. And I have no idea what's driving past me, so just give me a second. He's moving pretty fast. And then in everything we do, safety is a big concern. So beyond the typical, what I think FAST team members would be looking for in terms of safety, but any other slip, trip, fall hazards for our patient, staff, or members, or anything that is safety, that could cause a concern for safety issues. In terms of fire code, evacuation, shelter-in-place procedures, stuff like that, just ensuring that those things are in place and or helping should a FAST team member find themselves in that type of situation. Hurricane Dorian is a great example. They had a fire alarm and a tornado warning occur at the exact same time. And so having additional staff there to have eyes on of either identifying if there was a fire occurring and or helping ensure that patients and staff are well sheltered during that tornado warning, it would be a help as well. And then another big thing for FAST to consider if they're deployed to an SMSS is being that liaison between the shelter and human services branch. I don't know how great the communications is in this regard anyway. I think we have a tendency to work in silos, and with OEMS being stationed in emergency services while we're primarily providing a human service during this disaster, if we are able to leverage more human services capabilities and resources, it might help life in the shelter in general improve, but also, like I said, improve the overall capabilities for bringing people into the shelter who need to be housed in the shelter, but also helping in the discharge of those patients back to their homes or back to another facility. And something that human services does good is shelter and shelter operations and shelter coordination. So either passing information or helping be that liaison of, we don't have this resource. Can we leverage human services and some of our nonprofit partners?
This is Sherry again, and I want to clarify that when we're talking about human services branch, I believe you're talking about the branch in the Emergency Operations Center at the state level?
Yes, correct.
Great. And just to let you know, and just to let other people on the phone know that the FAST coordinator is actually located in the Human Services Branch breakout room. So there is that connection right there. And I think you hit it the nail on the head. I think it would be a great opportunity for that liaison position or duty.
Right. Yeah. The more we can keep OEMS informed about what's going on in the shelter world, and the more that we at the field level can keep emergency human services in the loop, I think it's the best is going to make the whole process of sheltering general population and medical needs individuals a lot smoother. So here's some sort of just some tips, I think, to help FAST team members from lessons learned that we've seen over the last couple of years in the response and then the growth of this program. And I know the capabilities of the FAST team are increasing by the day, and Sherry's doing a great work at that. So a lot of these problems, or not problems, but areas that we've seen some friction will improve over time. So when trying to make a first impression at the shelter, because there's no guarantee that in the operational briefing or that word is passed throughout the shelter that you are coming to the shelter to provide a service, is to ensure that you have the proper credential and uniform, or taking on that personification that you are a FAST team member will go a long way. When you get on site, it's important to sign in to the shelter, ensure that you're meeting all the shelter requirements for accountability purposes, and then try and make your way to shelter management. There'll be a lot of people walking around the shelter who are staff. They're going to want to know who you are and why you're there, and you could come across people with very rough personalities. You can come across people who are more than jovial and excited that you're there. But the sooner you can make it to a shelter manager position in the command staff with OEMS or in the command post, your experience in the shelter is going to be vastly improved, because that information is going to go out to everybody that you are there and you have a purpose for being there, and with the expectation of your role. Again, at the shelter, we provide meals. So if there's an expectation that if you are being deployed to a shelter, ensure that the shelter manager, shelter management staff know when to expect you, and if you are going to require a meal or an overnight accommodation. In some instances, they'll run out of space to accommodate individuals coming in from the outside world. We ran into this during Hurricane Florence, where we were definitely overstaffed to the point where we did not have any more beds for patients or for staff members. So it's important to understand that if there's an expectation for you to stay overnight or to be fed, that's a cost that the shelter is going to accrue, and/or displacing maybe a staff member from their bed, or not having a bed for you. And if there's enough time, those resources can be leveraged to ensure that your accommodation needs are met, but the sooner that information is communicated, the better. When you arrive, like I said, sign in the check-in desk, speak to the shelter manager, because they're going to be your conduit to the rest of the staff. The more professional and efficient with whatever tasks you are trying to accomplish in the shelter is going to also be a benefit to you. In the shelter, they are very focused on tasks and providing that medical care, and they really much do not appreciate anything or anyone that comes in that could jeopardize their battle rhythm, if you will. So the more the more efficient you can be with your task and understanding your task and role, and/or knowing not to get in the way of care being provided, is going to go a long way as well. And with that comes, professionalism. You're there representing FAST, NCEM, Human Services. So the more professional you can be in speaking to that level with the staff on site is going to be a benefit. report any, issues, findings, or thoughts that you have back to the shelter manager or the command staff. The last thing we want is for any kind of rumors to spread within the shelter environment. That way, if you're going up straight to the top, it can work its way down, as opposed to bringing a certain issue to the attention of a nurse or logistics person. Again, they might not have a full understanding of what FAST is and what your role there is. If you can bring it to a upper management or EMS personnel, they can make those changes and command decisions from the top down. And then, like I said, the big thing is try not to prevent any kind of medical care that's being provided to the patients. That's always our number one mission, is to ensure that care is being provided. This is who I am. This is my contact information, and our team leader at the coalition is Janice Brown, and her contact information. If you have any other suggestions or ideas or questions or interests, feel free to reach out to us. And I will sort of end it there. I just about made it an hour, Sherry, but I'll open up for questions, or I can talk about anything that I might have missed that we had talked about originally.
Thank you, Nicholas. Are there any questions at all?
Okay, because I'm gonna have to get ready and get off this one.
Anybody have any questions? Okay, get typing.
If anyone does have any questions, you're more than welcome to shoot them over to Sherry, or like I said, you can always shoot me an email and I'll respond as I can. So I know that was a lot of information about a lot of different topics. I appreciate the opportunity to share this with you guys.
Thank you so much, Nicholas. And this will be recorded. This is being recorded, so people will have the opportunity to access this at a later time as well. So thank you all, and thank you, Nicholas.
Thank you.
Thank you so much. Talk to you guys later. Bye.